Good evening. My name is Dr. Paul Tuttle. I'm a rheumatologist at OSMS, and I'm here tonight to talk about arthritis. And sorry about the delay in starting. We had some issues with getting this started. But as I discuss arthritis, feel free to type in the chat area some questions, and I'll get to those questions once I'm done discussing what arthritis is. So May is Arthritis Awareness Month, and you may have heard the term arthritis discussed by various people often. And the most common arthritis that we deal with in medicine is the degenerative or wear and tear type of process we call osteoarthritis. I specialize in inflammatory arthritis or an autoimmune type process, so it's not as common. And rheumatoid arthritis would be one of the more common types of inflammatory arthritis. And so arthritis just means a disorder of the joints. And so if you break up that into those two categories, inflammatory versus non-inflammatory, you can get a better picture of what that word means. So to help flesh that out, I wanted to share two stories or um, two patients and to differentiate between the two. So the first is Sue. So Sue has rheumatoid arthritis, so she has an inflammatory type of arthritis. She's 30. She had her third child, and then soon after she had her third child, started to develop some swelling in her joints, in her hands, in the knuckle area. She noticed something, and then started developing more stiffness. It started as 5 minutes, and then 10 minutes, and then a few hours, and then um, the joints would be red and warm, and it was both hands, and then all of a sudden, a month or two later, her knees were swollen, or her feet were swelling. The more she would do, the better she would feel. The mornings were always the worst for Sue, but as the day goes on, things got a little better. And then you have Bob. Bob has the degenerative or the more common type of arthritis. So he's 70, and he's had joint pain for most of his life, but definitely it's gotten worse over the last few decades. And mostly in his knees is where he feels it. And when he wakes up in the morning, he's got a few minutes of stiffness, but it's not too bad. He doesn't see much swelling in his knees. And yeah, the more he does, the more it hurts. So if he rests, he feels great. Mornings are always the best for him. So Bob's got that degenerative type of arthritis, and Sue has that inflammatory arthritis, rheumatoid arthritis. So you can between those two patients, between Sue and Bob, you can see the difference. How with an inflammatory process, you have that redness, you have that warmth, you have swelling, you have that stiffness that's prolonged, that's lasting hours. Tends to get better with the time as the day goes on. And Bob is almost the opposite, to where there's not much swelling. It's better in the morning. There's not much stiffness. And it's important to differentiate between these two types of arthritis because the treatment vastly differs between the two. So rheumatoid arthritis or inflammatory arthritis is where the body's attacking itself. You might have heard the term autoimmune disease, especially with COVID. The patients who get real sick with COVID, that's an autoimmune process where the body is attacking itself in different ways than rheumatoid arthritis, but in some similar ways at times. And you can think of it as like friendly fire. So your immune system should be good at knowing what's you and what's not you. So when a virus comes into your body, it recognizes it shouldn't be here, starts attacking it, and you get fever and all the typical symptoms when you get sick. But sometimes after infections, your body's confused and starts to see that virus in the joints and starts attacking the joints. So we call that friendly fire, as there's that confusion. So that's one of the theories of why autoimmune disease happens. Whether it's RA, whether it's a patient with COVID who's real sick in the hospital, multiple sclerosis, there's a long list of autoimmune diseases. So in rheumatology, I specialize in those that primarily affect musculoskeletal system, joints, muscles, tendons. And so because you have this confusion, this inflammation process, the treatment for it is vastly different. And so for Sue, with this rheumatoid arthritis that she has, so she's going to go on medications to help stop this friendly fire, stop this confusion, decrease the inflammation. And there's lots of tools in our toolbox, lots of medicines that can help us do that. For Bob, with the non-inflammatory type processes, not as much from a treatment perspective, at least with medications. Bob can try things like Aleve or Tylenol, and this may help a little bit. Sometimes you can get injections of your knee that can help some. Weight loss, Bob has gained a lot of weight in the pandemic, and so some weight loss, taking that pressure off the joints, may help some. But ultimately, as the joints wear out, just as tires wear out in a car, we have to get new tires, Bob may need a new knee. So you may see my colleagues down the hall, orthopedic surgeons, and have a knee replacement. And the prevention is often a question I get is how can we prevent these things? And we don't have a lot from a prevention perspective. For Bob, his weight probably is playing a role in this, but it's many reasons most likely. So people who have a lower body mass index, lower BMI, who weigh less, tend to have less osteoarthritis. But some of this is genetic, whether it's osteoarthritis or rheumatoid arthritis, and unfortunately we can't do anything about our genes, our genetics. People ask about anti-inflammatory diets, and we see that potentially with rheumatoid arthritis that there may be a trigger. If it's not a virus, maybe it's something in our diet. So could the way we eat decrease the incidence, decrease the frequency of having rheumatoid arthritis or other autoimmune diseases? And so that's one theory out there. We don't know for sure. But there's some evidence that maybe that's the case. Maybe that's the environmental trigger for people to develop an inflammatory process. But it's probably one of many triggers. As I mentioned, with COVID, a virus can do that. So we see it's probably one of the most common things we attribute to why people get inflammatory process would be some kind of infectious process. And unfortunately, we can't prevent that very well. So I hope that's a good overview. So when you have joint pain, you can tease out maybe yourself which one could it potentially be. So next, I want to go through some questions. We have some questions that were already sent to us prior to this Facebook Live event. So I'm going to go through those first, and then if there's questions that you guys have typed in with the chat here, I'll address those after I do these other questions. So the first question that came in before this live event is, what is OSMS doing to help keep patients safe during the pandemic? Well, we're like many other businesses where we're trying to keep people separated. So in the waiting area, when you check in, try to keep a good distance between people. We wipe down surfaces frequently. We ask that patients and their guests mask when they come in. We require that. And the same thing with our staff. We require our staff to wear a mask at all times. And of course, we're promoting the vaccine to help keep patients safe as well. And the second question is it safe to have surgery during the pandemic? And so I'm a non-surgeon, so I'll defer that question or the details of that question to my orthopedic surgeons down the hall, my colleagues down the hall. But in general, I can say that if you look at the studies, people who get COVID during a surgery is very, very, very low. the measures we do for patients who just come into the clinic to be seen are done for those who have surgery, and there's testing for COVID often prior to surgery. So the risk of developing COVID from a surgery would be very low in the studies that have been done. Next question is, why did you decide to become a doctor? Well, my dad's a physician and my mom's a nurse, so I grew up in a medical household, so it's always been an interest for me. And the main thing would be to help people. Rheumatology is an avenue in medicine that has lots of tools in our toolbox, a lot of medications to help people. So that excites me a lot, to be able to make a difference in somebody's life, to give them a medicine to somebody like Sue, who I can make her feel better and I can prevent damage. And the second thing is medicine is a puzzle. Not every patient's the same. So it's a puzzle, and I like that detective work of trying to figure out why people have the problems that they come to me with. The next questions are, X-rays 100% is showing and diagnosing arthritis? Well, nothing in medicine is 100%. So if somebody tells you something is 100%, that they're not telling you the truth, or they're misinformed. But there are various degrees of help with imaging. So plain X-ray is good at seeing fracture, but you can miss a fracture, and that's why often we'll repeat X-rays down the road. With rheumatoid arthritis, you can sometimes see inflammation damage there. We call erosions, where a piece of the bone is missing. But not always. Like sometimes, if it's early on, you don't see those in the inflammation damage. And then some people never get it, so you don't always see it there on X-ray. And then MRI is a better picture than just a plain regular X-ray, so you can see the tendons and the fluid, the ligaments, so much more detail in that picture, so it gives us a better picture of what's going on in the joint. But still, it's not perfect, and sometimes when the surgeon goes in, and they find things that you just didn't see on the picture in real life when they're looking at it with your own eyes. So it's helpful, but not perfect. And we definitely use that at diagnosing arthritis and trying to differentiate between, is this inflammation or non-inflammation? So the next question, is there any way to slow down osteoarthritis, like eating habits, exercise, etc.? So I talked about this some, where Bob, if he lost some weight, it may help his joints. If he exercised, the strength around the joints could help the pain. The next question, I talked about the difference between rheumatoid arthritis and osteoarthritis. Next is, what does rheumatoid arthritis feel like to most people? Does it vary based on degree? And so yes, it can vary a large amount from person to person. You get one person who's had it 5 or 10 years before I see them for the first time. It's very mild, very slow, gradual onset. Not much pain, but as the years go on, as it gets worse and worse, and eventually they come and see me. And then you have others where then one day they're fine, the next it's severe pain, lots of swelling, like fireworks. So and then there's everything in between of those two patients. And some it comes and goes. It can be, like I said, a consistent, gradual process for some, but others it waxes and wanes, but usually eventually it becomes more persistent, consistent. The next question is, if I have rheumatoid arthritis in my neck, is it other places? Usually the answer to that is yes. With rheumatoid arthritis, it tends to start in the hands and feet first before it goes to the neck. We don't see much RA in the neck as we used to, because we have such good treatment with medications, and we're diagnosing earlier than we used to. So we don't see that progression of the disease and that damage. But there is a rare person who can present just with inflammation in their neck or happen right away. But usually with RA, if the neck's involved, it's been going on for a while. Okay, so I'm going to move on here to the questions that you guys typed in. And so this one is, can you talk about GIA a little? How would parents know that this could be arthritis in their child and not just growing pains or something that will run its course? So good question. And so very similar to between Sue and Bob. So with kids can get this inflammation process too. So it's not just adults. So juvenile arthritis or juvenile idiopathic arthritis is an autoimmune inflammation process that happens in children or people less than 16 by definition of that term. And the presentation can be very similar, where you have the redness, you have the swelling, you have that stiffness. And in kids, it can be, especially young kids, more difficult. So I see adults and kids. And so when you get the young kids, they're not always as descriptive of their symptoms, as they just can't, they don't have that development to do that yet. So they may wince when they're walking around, they may be limping more in the morning. So there may be more subtle clues in the beginning before you would see any swelling, redness, or warmth. So if you remember Sue just feeling very, very stiff in the morning, you'll see kids who are limping or walking like an old man or an old lady. So parents will often say that. And then in growing pains, and that's what growing pains is a non-inflammatory process. So similar to what Bob has, it's a mechanical, structural process. Probably as children grow, or some people feel like maybe growing pains is for children who are a little more flexible, and because of that, their joints rub more. And typically, with the growing pains, you'll have a story where kids will have a active day with sports, or they're jumping on the trampoline one summer day, and then that evening they're laying in bed, not doing anything, and then that's when their joints tend to hurt after these active days. But then during the day, they're fine. They're not having that redness. They're not having that swelling. They're not limping in the morning. They don't seem walking like they're walking like an old man or old lady. So that's how you can differentiate between GIA or an inflammatory process in kids and growing pains. And a lot of the same labs and imaging we do for adults, we also do for children, because it's a very similar disease process. So the next question is similar. It says, can you speak a bit to GIA and knowing the difference between when our GIA kids just have an injury versus when it has lingered too long or changed into something where we should contact our rheumatologist? So yeah, so this question, whether it's a child or adult, so somebody who has a diagnosed inflammatory process, and you're wondering, is this an exacerbation? Is this a flare, as the term we use, of their underlying inflammatory disease, or do they just twist their ankle playing soccer, hurt their knee running, something like that? And it's a little more. That can be a little more difficult to tease out. So definitely, it's important to contact your rheumatologist to help with that. But often, with an inflammatory process, there tends to be less pain than with injury. It's not always the case, but so the more pain there is, the more likely that could be an injury. Bruising would be a good one. So say you twist your knee and you tear your medial meniscus, so it's not an inflammatory process, but you tear a piece of that knee, you'll see bruising sometimes. But it's difficult to tell, and sometimes time is helpful. A lot of things in medicine, time is a diagnostic tool, where if it's an inflammatory process, usually doesn't get better with time. If you just twist your ankle, it will. So definitely contact your rheumatologist if something like that happens. So next question. So when you have a patient that has an inflammatory arthritis, when do you initiate biologic? So that's a good question. So like I said, for Sue, having this inflammatory type process like rheumatoid arthritis, we have lots of good medicines to one, make her feel better, and to two, prevent damage. And you don't want to make the treatment worse than the disease itself. And so we have many tools in our toolbox, and some tools are bigger hammers than other tools. So you want to, you know, not use a sledgehammer when a hammer will work, will do the trick. So we start with the most mild medication first. So I think methotrexate's a very common one. Hydroxychloroquine. So some of these older non-biologic DMARDs or disease-modifying antiemetic drugs, we call them. So we start with the pills typically first, unless it's real severe. Sometimes we do start with biologics, but then if they don't improve enough with the more mild medicines, then we move on to the biologics. And the reason we save the bigger hammers for later is the biologics do often work better, but they have their own risks to them. Mainly, the main issue is infections, and so if you have less infections with these smaller hammers, then we'll save the bigger ones until we really need them. And some people, they get by just fine just with more of a mild treatment, but others, they need more help. But we have, like I said, lots of tools in our toolbox, and usually some combination will get there. I mean, there's a rare person where nothing works, unfortunately, but it's not too common for that to happen. And less common biologics. So if you talk to older rheumatologists in the pre-biologic realm, you would see lots of kids and adults with wheelchairs and these deformities that we're blessed not to have to see those anymore because we have these biologics. And the next question is, yep, oh, so that was part of the same question. Okay. So those, I believe, are all the comments, all the questions. Let me just make sure I'm not missing anything here. Yep, so that's everything. So feel free if there's other questions that come up and you didn't send a comment in here on Facebook, feel free to reach out to us. If you have concerns about with your joints hurting, then could you have arthritis, and if so, what kind of arthritis do you have? Feel free to call, make an appointment, book something online. But thank you for listening this evening, and have a good evening.